Noir Plasma Chrome Bleed. Unlocking knowledge, inspiring innovation, empowering curious minds.
This website makes learning so easy. I found all my resources here.
Like what you shares.
The structural complexity of the viscerocranium renders it susceptible to a range of traumatic injuries, congenital anomalies, and progressive degenerative disorders. Blunt trauma to the midface propagates along predictable lines. These fractures disrupt the vertical and horizontal buttresses. A key feature is the bilateral fracture of the pterygoid plates. Lefort I is a low-level horizontal fracture. It separates the mobile palate from the midface. Look for malocclusion and Guerin's sign. Lefort I, or Guerin's fracture, is a low-level horizontal fracture. It separates the mobile palate from the midface. Look for malocclusion and bilateral palatal bruising. A Lefort II fracture creates a large pyramidal segment. This separates the midface from the skull base, making it mobile. Look for raccoon eyes and epistaxis. A craniofacial disjunction is a severe injury. It separates the facial skeleton from the neurocranium. These fractures traverse through the orbital walls. Lefort fractures require open reduction and internal fixation. Access depends on the fracture level. Reconstructing the buttresses restores mid-foreapline rigid fixation. Craniofacial microsomia is a common condition. It may stem from a stapedial artery hemorrhage. This disrupts local neural crest cell migration. This results in underdevelopment of the jaw and ear. Craniofacial microsomia is highly variable. It is classified using the Omen's grading system. O stands for orbit, including orbital dystopia due to hypoplasia.
Nerve involvement typically affects the facial nerve. This leads to dynamic facial asymmetry. Mandibular hypoplasia causes a slanted bite plane.
Welcome to this overview of the primary muscles of mastication. Highlighted here are the temporalis and masseter muscles in a neutral state. They are essential for jaw movement and function. Cleft lip and palate are common congenital anomalies. They arise when embryonic facial prominences fail to fuse. This process occurs between weeks 4 and 7. A cleft lip is caused by a failure of this fusion, which may be unilateral or bilateral. This results in a persistent labial groove, from a minor notch in the vermilion border to a complete division through the nasal floor.
Between weeks 6 and 9, the secondary palate forms. Palatal shelves grow downward, then elevate above the tongue, separating the nasal and oral cavities.
A cleft palate is caused by a failure of fuse. This creates a direct connection between the oral nasal cavities, leading to problems with infant feeding, nasal regurgitation, and speech development. The VY pushback creates anterior bare bone exposure. This can restrict future maxillary growth. Furlow Z-plasty uses mirror image flaps. It preserves long-term maxillary growth. The VY pushback palatoplasty utilizes mucoperiosteal flaps to close the cleft. However, this technique exposes extensive areas of bare bone. This can restrict maxillary growth. Alveolar bone is a highly dynamic, specialized tissue. It undergoes continuous remodeling to maintain its structural volume and density. Alveolar bone consists of 67% inorganic minerals, primarily calcium hydroxide, mainly type I collagen. This composition provides needed flexibility and strength. Following tooth loss, bone stimulation ceases. This triggers rapid disuse atrophy. At the cellular level, expect a 40 to 60% ridge reduction, this collapsing lips and facial wrinkles. Osteocytes control bone remodeling by balancing two key factors. Rankle binds to precursors, driving osteoclastogenesis, while OPG acts as a decoy, blocking this interaction.
RANKL is a polypeptide member. It is expressed by osteoblasts and activated T lymphocytes. It binds to the rank receptor.
Rank is expressed on osteoclast precursors. The binding of RANKL activates downstream signaling. This drives the fusion and survival of active osteoclasts.
OPG is a decoy receptor produced by osteoblasts. It binds to RANKL, blocking its interaction with the rank receptor. This inhibits osteoclast differentiation and bone resorption.
In a healthy system, the RANKL to OPG ratio is tightly regulated to maintain balance. However, in chronic periodontitis, periodontal pathogens trigger an inflammatory response.
Cytokines stimulate lymphocytes and periodontal ligament cells, increasing the RANKL to OPG ratio. This shift accelerates osteoclast, leading to progressive bone loss.
Cranial neural crest cells Hox-free zone. This establishes the facial skeleton via a nested DLX code. This gives rise to complex bony structures.
Deep in your ear and neck lie bones with a surprising link. The ossicles and hyoid share a common embryonic origin. While one drives hearing, the other supports our speech. They are marvels of comparative anatomy.
Human head and neck contain specialized structures, the auditory ossicles, while the hyoid bone protective visceral anchor. Both originate from the pharyngeal arch apparatus.
The ossicles bridge the gap to the cochlea, while the hyoid bone acts as a free-floating visceral anchor. Investigating them provides insights into conditions from hearing loss to trauma.
The tympanic cavity houses the ossicular chain. CBCT enables precise modeling for prostheses. The malleus is the most lateral ossicle. It consists of a head, neck, and handle. This handle is attached to the tympanic membrane. It extends to its apex, known as the umbo.
The malleus head is situated in the epitympanic recess. An elliptical facet marks the junction with the incus. CBCT evaluations demonstrate sexual dimorphism. Males exhibit larger head widths.
The incus, or anvil, features a bulky body. Its short process anchors in the fossa incutus. The long process descends parallel to the malleus. Articulate with the stapes.
The stapes is the lightest bone in the human body. It consists of a head, neck, two crura, and an oval base. The footplate transmits sound waves to the inner ear.
We found significant differences in the malleus total length. The head width also varied between male and female cohorts. Looking at the standard literature parameters, the incus has an average height of 6.8 millimeters and a width of 5.3 millimeters. Specific cohort data was not available. Let's analyze the morphometric parameters of the stapes. Literature shows an average height of 3.5 millimeters, but timing and C-scans reveal significant variations. Let's examine the specific cohort data. We analyzed the CBCT morphometric parameters. The external auditory canal, the superior semicular canal, was identical in both. This highlights specific sexual dimorphism in cranial anatomy.
The incuto-malleolar joint is a true synovial joint. It connects the head of the malleus to the body of the incus, ensuring a coordinated transfer of energy.
The incuto-stapedial joint articulates the incus with the stapes. Historically, it is classified as a ball and socket joint. The stapes footplate moves within the oval window. Medially, it is secured by the annular ligament. It acts as a spring, allowing it to displace the inner ear fluid. This prevents the escape of paralymph.
The middle ear develops from the pharyngeal arches. Ossicular templates derive from the neural crest core. They undergo endochondral ossification.
Meckel's cartilage, the skeletal rod of the first pharyngeal arch, gives rise to the precursor blastema of the malleus, its ancestral motor innervation via the mandibular branch of the trigular branch.
Reichert's cartilage of the second arch develops into the stapes superstructure, the styloid process, and stylohyoid ligament. The stapedius muscle is innervated by the facial nerve.
During early development, the pharyngeal arches begin to form. The first arch gives rise to the malleus and incus, while the second arch forms the stapes superstructure.
The dual arch hypothesis proposes that the ossicular heads develop from the first arch, while the inferior parts derive from the second arch. This explains isolated anomalies like microtia.
Recent reconstructions show that both the malleus and incus emerge within the first pharyngeal arch, suggesting that abnormalities reflect localized signaling failures. In contrast, the stapes footplate has a well-documented dual origin, branchial arch. However, the medial portion originates from the otic capsule, which is of mesodermal origin.
During development, the stapedial ring fuses with the lamina stapedialis. This fusion forms a unified does not develop. This shows a strict developmental dependency.
Sound waves travel through the air as pressure variations. The middle ear acts as a mechanical transformer. It matches impedances between air and fluid, amplifying sound pressure to prevent energy loss.
Sound waves enter the ear as acoustical energy.
they vibrate the tympanic membrane. The ossicular chain amplifies this pressure, creating fluid waves in the cochlea.
The middle ear overcomes impedance mismatch. The eardrum collects force. It focuses it on the tiny stapes. This creates an area ratio of 18:1. This amplifies pressure for the inner ear. The malleus and incus form a physical lever. Rotation occurs around an axis between the processes. The malleus lever arm is 1.3 times longer. This increases the force at the stape's footplate. The eardrum's cone shape creates a catenary lever. Its fibers buckle, moving more in intermediate zones. This action doubles the force applied to the manubrium, yielding a total pressure gain of nearly 47 times. This pressure boost provides a sound gain of 20 to 30 dB. It recovers energy lost at the air-fluid interface. Below 1 kHz, this gain averages 23 dB, but it decreases sharply above that frequency.
Standard tympanometry uses a 226. At this low frequency, the middle ear is stiffness dominated. A loud sound triggers muscle to contract, stiffening the chain and reducing sound conduction.
Below resonance, added stiffness reduces the system's admittance. With a higher probe tone, mass reactance dominates the system. This differentiates stiffness from mass pathologies.
Otosclerosis is a bone remodeling disorder. Dense bone is replaced by cellular, spongy bone. This restricts movement, causing hearing loss.
This spongy bone subsequently mineralizes into disorganized, dense sclerotic bone, the inactive sclerotical microfissure situated immediately anterior to the oval window niche.
As the focus expands, it calcifies the stapes annular ligament. This fixation impedes vibration, reducing sound energy transmission. Clinically, as hearing loss.
This shows a typical 20 decibel dip at 2 kHz. First, fluid inertia causes the inner ear fluids to shift. Compressional distortion squeezes the capsule. Third, ossicular inertia moves the suspended chain. The middle ear ossicles resonate. This vibration is most efficient between 1 and 2 kHz. Otosclerosis fixes the stapes. This eliminates their inertial contribution. This mimics sensory neural loss.
A prosthetic piston is crimped to the long process of the incus, bypassing the fixed stapes. This bone conduction notch disappears, a phenomenon known as overclosure.
Longitudinal fractures often disrupt the ossicular chain. Transverse fractures directly violate the bony otic capsule.
Traumatic forces can dislocate the ossicular chain. The heavy incus is particularly vulnerable. It lacks the protective muscular anchoring of the other bones.
This anatomy makes the incus the most commonly dislocated ossicle. Incutostapedial joint separation is the most common form. A shearing force tears the delicate joint.
This is the normal incutomalleolar joint. Trauma causes separation of the bones. The ice cream cone shape is lost on CT. This is complete luxation of the incus. It separates from the malleus and stapes. It rotates directly into the mesotympanum.
Like what you shares.
This website makes learning so easy. I found all my resources here.
Noir plasma chrome bleed. Unlocking knowledge, inspiring innovation, empowering curious minds.